Welcome to This Explainer. Today we're diving into the sheer precision, the delicate chemical balance, and the incredibly strict protocols involved in every single drop of transfused blood. We are essentially looking at the exact blueprint of a lifesaver. So let's get right into it. Here is a quick look at what we'll be covering today. We've got transfusion basics, components and storage, blood preservatives, the crucial timing of the process, medical staff responsibilities, and finally, potential transfusion reactions. All right, Section 1, Basics of Blood Transfusion. So what exactly are we talking about here? Well, simply put, a blood transfusion is a medical procedure where donated blood or very specific components of that blood are delivered directly into a patient's bloodstream through an IV cannula. The absolute key takeaway here is that it's an immediate, direct delivery system straight into the circulatory system. There is no middleman. Now, when most of us hear blood transfusion, we probably picture a chaotic ER, right? Someone suffering from severe blood loss after a traumatic accident, or maybe undergoing a massive complex surgery. But actually, they're equally vital for chronic systemic conditions. We're talking about severe anemia caused by things like kidney failure or iron deficiency. They're also heavily used as supportive care during cancer treatments like chemotherapy, which completely depletes a patient's blood cells, and for managing lifelong blood disorders like hemophilia and thalassemia. Moving right along to Section 2, Components and Storage. This is where it gets like a giant logistical puzzle. Different blood components require entirely different environments just to survive. Whole blood and red blood cells, they like it chilly, kept between 2 to 6 degrees Celsius, and they can last up to 35 and 42 days respectively. But platelets, they need a much warmer room temperature of 22 degrees Celsius and only survive for about 5 days. White blood cells, they tap out after a mere 24 hours. On the complete opposite end of the spectrum, you have fresh frozen plasma and cryoprecipitate. Those are kept in a deep freeze between -20 and -40 degrees Celsius, which allows them to sit safely on the shelf for an entire year. Which brings us to Section 3, blood preservatives. So how do we achieve that incredible 42-day longevity for red blood cells? It doesn't happen naturally. Medical science relies on a very specific chemical life support system known as the CPDA preservative formula. Every single ingredient has a job to do. The C is for citrate, which binds to calcium ions. The P is phosphate, which actively prevents coagulation, keeping everything flowing smoothly. D stands for dextrose, serving as a much-needed energy source for the living cells trapped in the bag. And finally, A is for adenine. Adenine is the real MVP here, single-handedly pushing red blood cell viability all the way up to that impressive 42-day mark. Let's look at Section 4, timing the transfusion process. Once that blood is ready, it is literally a race against the clock. Blood must be transfused within 20 to 30 minutes after being issued from the blood bank. The second a bag leaves that perfectly controlled, temperature-regulated fridge, the countdown starts. It absolutely cannot just sit on a counter. It has to reach the patient's bedside immediately. And the speed of the actual transfusion depends entirely on the component. Whole blood and red blood cells give you a little bit of breathing room. They need to be completely transfused within 4 hours, though ideally you want it done in 2. However, for things like platelets, fresh frozen plasma, cryoprecipitate, and white blood cells, 30 minutes tops. This incredible speed is absolutely vital, especially with the colder components to prevent a terrifying condition called cardiac dysrhythmia. That's where the patient's heart rhythm is actually thrown off by the sudden rush of freezing cold fluid entering the body. Okay, Section 5, Medical Staff Responsibilities. Because of all these high stakes, medical staff operate under a rigid, bulletproof safety checklist. Before a single drop of blood even enters the patient, there is a mandatory dual verification system. 2 registered nurses, or a nurse and a doctor, must confirm the blood is a flawless match for the patient. Step 2 is really fascinating. They first infuse a 0.9% normal saline solution. Why? To clear out the IV line and prevent hemolysis, which is basically the unwanted destruction of red blood cells. Then, finally, they take a full set of baseline vital signs. 100 degrees Fahrenheit. Remember this number, because it's the body's own biological red light. If a patient's baseline temperature is 100 degrees or higher, the transfusion usually stops dead in its tracks. Administering blood to someone already running a fever is incredibly dangerous because that fever could completely mask a severe transfusion reaction or just make an underlying infection that much worse. If they're clear to go, the administration itself is meticulously paced. At minute 0, they start at just 10 drops a minute. It's basically a test run. At minute 15, they check the vital signs all over again to make sure there are no immediate red flags. Assuming everything looks good, At minute 16, they finally open the line a bit more, increasing the flow to 15 to 30 drops a minute. And from there, it's nonstop, hourly vital sign checks to ensure absolute safety until the bag is completely empty. Finally, Section 6, potential transfusion reactions. Even with the most flawless protocols in place, things can go sideways while the blood is still flowing. We're talking about acute reactions that range from a mild, itchy allergic response all the way up to full-blown anaphylaxis. You can also see febrile non-hemolytic reactions, acute hemolytic reactions where the patient's body literally attacks the new blood cells, and severe lung complications like transfusion-related acute lung injury. And crazy enough, patients can even suffer toxicity caused by the very citrate used in the CPDA formula to preserve the blood, or experience wild electrolyte imbalances like hypocalcemia and hypercalcemia. And the vigilance doesn't just stop because the IV is removed. Delayed issues can pop up days, weeks, or even much later. These include delayed hemolytic reactions and something called transfusion-associated graft versus host disease, which is wild. It's where the donor's white blood cells actually start attacking the recipient's body. There's also post-transfusion purpura, dangerous iron overload known as hemosiderosis from getting too many transfusions over time, and of course, the ever-present, though heavily screened, risk of transfusion-transmitted infections. So let's take a step back for a second. When you consider this incredible chemical balance and the intense, strict timing required that we've just unpacked together, how might future medical innovations make this process even safer? As we look at the almost dizzying level of coordination required today, from the chemistry of the CPDA formula to the hourly bedside vitals, how do you think future technology will continue to perfect this blueprint of a lifesaver? Thanks for joining me for this explainer, and stay curious.